Coming to the topic for today, I think I'll start sharing my screen. So the topic today is something which concerns everyone, but somehow very few people are working on it, including even among NGOs and social movements, and that is regulation of private hospitals to protect patients. And this is something which concerns obviously working class people, poor people in urban and rural areas, but also the middle class on a very large scale. And as I will describe, it's a huge topic, but it's like the dark side of the moon. Somehow we tend to not think about it or not give it so much attention, although it is so important for the well-being and protection of patients in India. Let's first look at a few recent news items. So this is the first story is about a patient who died in Ahmedabad in a private hospital. And after the death, they paid the entire amount, the bill of 1.65 lakhs. After some time, they went to collect the body, and then they were said that the doctor has seen the dead patient. So another 23,000 rupees have to be paid. Without that, we will not release the dead body of the patient. Now, this may look like a small incident, but it shows us what is the level of impunity and the level of violation of rights and the level of vulnerability that people face in private hospitals today across the spectrum. Rural people, urban poor people, middle class people, upper middle class people, no one is spared. The second news is about just a few months back from Ghaziabad near Delhi. So here a man died in a private hospital, and when the inspectors went there, they found that there were no doctors in the hospital. And it was running as a private hospital and charging money to people. So this shows you that lack of standardization and lack of regulation can be devastating. We have stories of patients who were operated in hospitals which did not have a surgeon, which did not have a trained anesthetist, and children died there because they were very badly operated and in fact practically mutilated. So this is lack of this is the price that we are paying for lack of regulation of private healthcare. And somehow this has not yet become a major political agenda or even a major social agenda. The third is a story from Noida, again near Delhi. The patient was actually insured and they had insurance coverage of 10 lakhs. So you might be thinking, I mean, of course, in US, insurance is at a different scale. Even in India, many people do have some form of health insurance, but it doesn't work all the time. In fact, it often does not work very well. So here this patient was insured for 10 lakh rupees. The bill came to 17 lakh rupees. And then the hospital said that until you deposit the remaining 7 lakhs, for 3 days, the hospital detained the dead body of the patient until the 7 lakh rupees was paid. So these are just a tip of an iceberg of what is happening in private hospitals across India today. What happened in COVID? It's a whole huge topic, and perhaps you already will be knowing many of these stories. This is a woman begging for a hospital bed outside one of the private hospitals. In COVID, we saw how private hospitals massively overcharged patients. The average cost of COVID-19 patients, treatment in Delhi was 3 lakh rupees, 300,000 rupees, which is 2.5 times an annual income of an Indian. One hospitalization wipes out 2.5 years of your total income. What is notable is that Indian households, from their own pockets, spent more than 3.5 times more than what the government spent on COVID treatment. Actually, people are paying huge amounts from their bank accounts, from their savings, by selling assets, by borrowing, by taking loans, just to meet hospitalization care in private sector. In COVID, it's estimated that about 25 to 50% of households in India had catastrophic healthcare expenditures. And 20 crore people additionally fell into poverty. India already has a huge number of people under the poverty line, but because of hospitalization expenses, 20 crore is 200 million people, a huge number. I mean, this is the kind of situation that we are facing, and which in COVID became even more sharply highlighted. Sathi did a study during COVID and where we analyzed the actual private hospital bills of 100 patients in different parts of Maharashtra who had COVID. And we analyzed that how much did they actually pay for the treatment compared to the rate capping which had been declared by the government. And here you can see that in small and medium-sized hospitals, the rate, according to rate capping, they should have been paying around 8,000 rupees per day. They actually were paying more than 33,000 rupees per day. In medium hospitals, again, it is around 8,000 rupees, but they're actually paying about 38,000 rupees or more than that per day. And in large hospitals, the expenditures were of the range of 40,000 rupees per day. Now imagine a person, an ordinary person having to pay 40,000 rupees every day. So we analyzed these expenses and we found that they were 4.3 to nearly 5 times higher than what the government had declared. So 5 days of hospitalization would cost somewhere near 2 lakh rupees, and that would wipe out the entire annual income of an average Indian. 5 days of hospitalization, that's it. And in COVID, there were many, many families which had to undergo multiple hospitalizations for a much larger number of period of time and so on. So you can imagine how devastating this has been, all because of the lack of regulation. So we have this huge giant of private healthcare, which has managed to keep itself completely unregulated. And whenever we try to regulate it, any kind of civil society effort is made. As Arvinda mentioned, there's a huge backlash, and we are told that nobody has a right to regulate private hospitals. India has the third largest number of dollar billionaires in the world. There are only 2 countries in the world which have larger number of dollar billionaires than India. You must be knowing them. Of course, you're living in one of those countries, which is the US, and the second is China. Now, that is one point, that India also has the largest number of poor people in the world. But what is more interesting for our discussion today is which industry is generating these billionaires. So in 2022, which Oxfam did an analysis, which industry has generated the largest number of dollar billionaires? Are you aware of this? It was healthcare and pharma. So this unimaginable amounts of wealth was being generated from patients who were paying exorbitant amounts often in private hospitals and for privately manufactured pharma. Just in 2022, 7 new billionaires were generated in the healthcare and pharma sector. The total wealth of India's healthcare billionaires and in 2022, which is now increased, is 9.37 trillion rupees. Just for comparison, India's total public health expenditure, the central government and all state governments put together in roughly the same period, was barely about 1/4 of this. So we are only talking about the top billionaires. We are not talking about the millionaires and the many, many other private hospitals. So something peculiar is happening here. On one hand, public hospitals are underfunded, understaffed, and in various ways constricted for their budgets and operations. And on the other hand, we have an absolutely booming private healthcare sector, which is completely unregulated in the level of profits that it can make. And currently, we are doing a study on the level of profits that are made by private hospitals. And some of the figures that were coming up, you will be astounded. So in India, India has one of the most privatized healthcare systems in the world. We barely spend about 1.3% of the GDP. This is a little older figure. Some more recent estimates say it's about 1.5, but it's definitely much, much less than the 5% figure, which is desired. If you make a list of 190 countries across the world, then India is in the bottom 10 as far as public healthcare spending is concerned. 70% of healthcare provisioning in India is from the private sector. Almost all of them are for profit. At least 50% of healthcare spending in India currently is out of pocket, even according to official estimates. Unofficially, it is estimated to be about 2/3. Every year, a country equivalent to the population of maybe Australia or Germany is pushed into poverty just because they cannot pay healthcare expenses. And despite all this huge giant has managed to keep itself completely unregulated. There is no regulation on costs of care in any private hospital across the country, except for a short period during COVID, only for COVID care. There is no regulation of clinical standards, of treatment practices, whether an operation or an injection or an investigation is rational or irrational. There is no regulation. And there's practically very little protection of patients' lives. So this is it's a critical situation which we are dealing with. Now, this is one of my favorite slides about the two wrestlers in the Indian healthcare system today. So the big wrestler, the Bada Pahalwan, is profit logic. And profit logic is ruling the healthcare system. It basically says that if you have some money, you'll get some healthcare. If you have more money, you'll get more healthcare. If you have too much money, you'll get too much healthcare, which you don't even require. Your uterus may be removed. You may have to undergo an unnecessary cesarean. You'll be given an MRI scan. And if you have no money, you'll get no healthcare. That is what the profit logic dictates. Against this profit logic, there is a Chota Pahalwan. There is a smaller wrestler called social logic, which holds that health and healthcare are basic human rights, irrespective of economic, social status, caste, religion, gender, or any other aspect. Every human being must have a right to healthcare. Today, this is actually the main contention in the Indian healthcare system. And when people ask me, कि आप तो बहुत सारी बातें बताते हैं, तो simple में बताइए क्या करना है? So my answer is a one-line answer. The big wrestler should become small, and the small wrestler of social logic should become big. And when we say the big wrestler should become small, what we mean is regulation. That this profiteering, excessive profiteering, exorbitant profiteering must stop. Irrational care, unnecessary care, wasteful care, unnecessary medications, operations, investigations must stop. And that is only possible through regulation. My colleague, Dr. Arun Gadre, and myself, we had written a book called Dissenting Diagnosis. As doctors, we interviewed 78 whistleblower doctors across India, and they gave us information about what is actually going on today in private hospitals. The stories were, some of them were so shocking, this book became a bestseller at that time. The instances of irrational medications, unnecessary interventions, massive overcharging, compromises on quality of care, and unethical practices like commissions and kickbacks. This is the reality. And unfortunately, in the last 8-10 years since this book was written, the situation has not improved. In fact, it has worsened, and I'll come to that very shortly. What are some of the irrational practices in the private medical sector in India today? Unnecessary injections. We did a study where we found that nearly 2/3 of outpatients in rural areas will be given injections, whereas barely 5% actually might have required it. Unnecessary saline infusions, antibiotics, steroids, vitamins, so-called tonics, and many, many other expensive versions of medicines where the basic and much less expensive versions are equally effective and sufficient. Various varieties of blood tests and investigations, CT scan, MRIs, cesarean section, which I'll come to in my next slide, hysterectomies, angiographies, angioplasties, cardiac bypass, various kinds of orthopedic operations, including knee replacements and so on, being overperformed on a large scale. So it's a paradox. On one hand, people are suffering because they do not get enough healthcare. On the other hand, a significant section of the population is being bombarded with unnecessary healthcare. This is the market failure. Now let's have a quick look at cesarean section rates as an example. Now here you can see the green areas are where cesarean section rates are less than 50%. Yellow areas are 50 to 75% women are undergoing cesareans. And red areas where Telangana, interestingly, is the biggest, and also to some extent Andhra and West Bengal and even parts of Tamil Nadu and Karnataka, 75% or more of women are delivered through a cesarean section. Now, how is this distributed across classes? Which tells us about the inverse care law. So the inverse care law means that you are given medical care not according to your medical need. In fact, it's inverse to that. So the more the medical need, the less the care. The less the medical need, the more the care. So the poorest 20% of women in India, they have a cesarean section about 7% of the time, which means that many women, they die because they do not get a cesarean section in time. Because it's estimated that about 15 to 20% of women during labor, they genuinely scientifically require a cesarean section. So here it's only 7%. And then the richest section is almost 40%, 40, which means that many of these women, perhaps most of these women, actually do not require these cesarean sections. Now let's see the breakup as per public hospitals versus private hospitals. So in public hospitals, 14% of deliveries are by cesarean, which is more or less close to the WHO norm of around 50%. In the private sector, on the other hand, it is nearly 48%. So which means that 2/3 of the cesarean sections taking place in India today, every day, on the scale of lakhs of births every day, 2/3 of these cesarean sections are absolutely scientifically unnecessary. What is being done? I mean, this is just one example. There are so many other examples. We don't need any more logic now. What we need is action. But what we have instead is something even more problematic. We are now doing another study on corporatization of healthcare and private equity. And I'm pretty sure that even in the United States, private equity in healthcare and in hospitals is not a positive input. So firms like Blackstone and KKR and Carlyle and so many other private equity firms, international financing, sovereign funds are coming into India and reaping huge profits from healthcare. So they come in, they invest for about maybe 3 years, 4 years, 5 years, and they double their investment and exit. That shakes up the entire hospital. It distorts the entire treatment practices in the hospital. Now let's come to what has been done by the government and what needs to be done by people and governments. So we have, as Arvinda mentioned, 15 years back, the Parliament of India passed a very important legislation called Clinical Establishments Act. And its rules were passed in 2012. So basically from roughly 2012 onwards, across various states, private hospitals were supposed to be regulated. So far, it's optional for states to take up this act. So 12 states and 6 union territories, they have adopted this central seal. So 12 states, maybe roughly about 40% of the country. And these rules They include a provision for rate transparency, which is absolutely critical. Have you ever gone to a restaurant or a shop where you wanted to buy something and you said, can you tell me how much does it cost? And they told you, no, no, we cannot tell you how much it's going to cost. You just have to buy it. I mean, we are talking about the market. We're talking about the free market. We're talking about promoting the market. Isn't this a basic principle of the market? That there needs to be transparency. But unfortunately, these rules, which were passed in 2012, for such a basic provision like transparency of rates, are yet to be implemented. One step further is rate standardization. That there needs to be some standard for these rates. That also is yet to be implemented. Standard treatment guidelines. When is a cesarean required and when is it not required? When is an MRI scan genuinely required and when is it not required? And doctors need to follow those guidelines. So the technical work has been done. The formats are available. The guidelines are available. It's not held up because of technical reasons. It's held up because of some other reasons which probably you can think about. And you saw that big wrestler. So that big wrestler is very powerful. You can imagine our government, which wrestler is it primarily listening to? The small wrestler or the big wrestler? Actually, these rules were shaped by discussion in Parliament. There's a huge discussion in Parliament that why private hospitals have not yet been regulated and they need to be urgently regulated. 15 years down the line, this essential act has still not been implemented. Why has it not been implemented? Because after the act and the rules, the next step was notification of standards, which was legally supposed to be done by 2014. After more than a decade since then, these basic minimum standards have not yet been notified by the government. Unless you have standards to register hospitals, you cannot register them. And unless you register hospitals, you cannot regulate them. So this is not rocket science. These standards are also available since the last 6 years. They're all sitting on the government websites. You can see them, but they've not been notified. And unless they are notified, no effective regulation can take place. And similarly, no standardization of rates has been implemented. And you can see this big wrestler has exerted huge pressure on the government to not regulate it in any form. The big wrestler wants to become bigger and bigger, and it wants to keep the small wrestler smaller and smaller. So 15 years down the line, this essential act in India, I don't know how many people know about this, how many people talk about this, how many messages circulate on WhatsApp groups when we complain about various things, that our government has a very important act to protect patients, to protect millions of patients. Every day people are being cheated, looted, and exploited in private hospitals, and the act is not being implemented. Maybe we should do something about this, at least on the social media. Anyway, so various states across India, there are 4 kinds of states. The first large category is 12 states which have adopted the central CA, but they have not implemented it. Then there are some other states, important states like Tamil Nadu, Kerala, Punjab, Andhra Pradesh, Chhattisgarh. They have adapted their own state level acts, which are kind of similar to central CA, with some dilutions, some modifications. And here also the status of implementation is, I would say, relatively minimal. There are 2 states, Karnataka and West Bengal, which have implemented their own state-specific acts with some additional features and which are interesting. Here also there has been a huge pushback by the private healthcare sector, saying that we don't want this kind of regulation. Here also the level of implementation which was required has not happened. Still much more needs to be done. And then there are many other states like Maharashtra, Gujarat, Delhi, Madhya Pradesh, Odisha, where we have very outdated acts. Now, can you imagine Maharashtra? We think that Maharashtra is a very developed and, modern state. Mumbai is the financial capital of the country. In Maharashtra, the act, if you can call it an act, which is supposed to at least register private hospital, is dated 1949. 1949, 2 years after independence. Can you imagine what must have been the private healthcare sector in 1949 and what it is in 2025, but we don't have a new act? Nearly 75 years, nothing new has been done. Now, what is going on? I mean, how can we say that we are a modern, civilized, technologically developed country when we have such outdated acts and, regulation is completely stalled? Obviously, technical issues are not the main problem. There's some other problem. Now, this is part of the picture. As you know, there are these electoral bonds, which big corporates and big companies can buy to support political parties. One of the largest number of electoral bonds were purchased by 30 big pharma and healthcare companies. When the electoral bond list, after a lot of resistance from the government, when the Supreme Court insisted, and the electoral bonds are only a tip of the iceberg of electoral, funding. of political parties by corporates. On the top were pharma and healthcare giants. The biggest donor in the healthcare sector was a Telangana hospital chain, which was under a huge number of other, inquiries and, various kinds of corruption charges. So now this big Pahalwan is being given continuous steroids by the government. That's why it's become so big. And the Pahalwan is in return, obviously, satisfying those parties which are in government. And it's not only the central ruling party, even other parties are probably involved, but the central ruling party is the most prominent. So this is part of the picture. What needs to be done and what is already on the table? What are the tools that we have? It's not a completely, a negative situation. There are obviously over the years, many efforts have been made, and some of these efforts have to some extent moved ahead, but they need to be further supported now. One important such provision is the Patients' Rights Charter. I have been a member of the National Human Rights Commission Core Group on Health since the last more than a decade. As a member, I proposed to the NHRC that we should have a Patients' Rights Charter. And then I helped the NHRC to draft this charter. After the NHRC drafted this charter, now the Union Health Ministry has taken up this charter. And now with some updating in 2021, there are 20 patients' rights which are endorsed in this National Patients' Rights Charter by the Union Health Ministry. These are all very basic rights. Right to information. Any patient should know what is their illness, what is the diagnosis, what is the line of treatment, what are the likely complications, what are the costs. Any hospital should actually display its rates, but by and large, it's a very, very basic right. Right to all records and reports, right to informed consent, right to confidentiality, human dignity and privacy, right to non-discrimination. A person from any religion, caste, rural or urban background, any gender, and any other socioeconomic background, there should be no discrimination. Right to second opinion, right to choose alternative treatment options, right to care according to prescribed rates, right to choose the source for buying medicines. So the hospital actually has no right to force or pressurize the patient and their relatives to buy medicines from the hospital pharmacy, because often they may be hugely inflated, the cost. So the same medicine may be available at half the price outside the hospital. The right to refer and transfer rights to clinical trials, right to take discharge or to receive the body of a dead patient. And to publicize these rights as Sathi, we published a series of posters, pictorial posters, cartoon kind of posters, so that people can understand. These posters are entirely based on the government charter. And we have brought these out in Hindi and Marathi so far. It will be good to also translate these into other Indian languages. We have tried to circulate these, but so far, probably these still need to reach many, many more people. So this is one important tool that we have, the Patients' Rights Charter. A few years back, just before COVID, as Jan Swasthya Abhiyan, we organized a major demonstration at Jantar Mantar in Delhi. Until then, it was possible to organize demonstrations in a major way. One of the main demands was to implement the Patients' Rights Charter, because until then, the Union Health Ministry had not done much to actually even notify these rights. So that led to this one step, and the further steps of implementation are still to be taken. Now, as Arvinda mentioned, in Maharashtra, as Sathi and with support from AID, we have been engaged in a whole range of processes, which I'm not talking about in detail today, because I think that has already been shared in different forms by the Sathi team. But I'm just very quickly in a couple of slides reiterating that in Maharashtra, there are certain rules under the Maharashtra Nursing Home Registration Act. The act is very outdated, but there are some recent rules which are sort of a kind of saving grace. A, they have to display the Patients' Rights Charter. B, they have to display their rates. And C, all municipal corporations, cities and all districts have to set up grievance redressal cells to assist patients and have toll-free numbers which should be displayed in all hospitals. Now, this has been an uphill battle, but we have basically, with some support from AID and to quite extent also through voluntary efforts, been trying to publicize that these basic provisions must be implemented in all private hospitals across Maharashtra, Sangli, Pune, Nashik, now Solapur, and also a few other places like Ratnagiri and Sindhudurg. And, we are pushing for this implementation. And it has led to some partial success. Wherever people have been informed, social organizations have been involved, the local officials have also been actively sensitized, their implementation has started. As you saw in the previous slide of the rate display, some hospitals have started displaying rates, at least the 15 rates which are mandated by law. So it is possible to make these changes, but it requires a lot of mobilization and effort. And toll-free numbers have also been started in 4 cities and districts of Maharashtra because of these efforts. Now, finally, coming to a larger action, you must be wondering that if a law has not been implemented over the last 15 years, and it's a major law involving public interest, something needs to be done. We also, as Jan Swasthya Abhiyan, realized this, and after making various other kinds of efforts, finally, we decided to file a public interest litigation in the Supreme Court of India. And this was filed in January 2021, actually just at the time when the COVID second wave was going to start. And for the first 4 years, nothing happened. Supreme Court also moved slowly. Since last year, hearings have started. We had an important hearing in April 2024 last year. The court said basically that all hospitals have to observe standard charges and the government has to come out with the standard charges. Otherwise, we'll enforce CGHS rates for private hospitals. And once this happened, then the private hospital lobby, suddenly they became hyperactive. And they brought in these top lawyers who are extremely highly paid. And they're basically paid to argue things which cannot be logically justified. But they argue it in some legally sophisticated way. So they basically said that the government has no right to regulate us. The government cannot regulate rates of private hospitals, despite the fact that there are rules in force. Anyway, so after that, then we also counter-mobilized, and the Consumer Voice and Veterans Forum have also impleaded in the Supreme Court. And now the recent most hearing which took place last month, the court said that there's no stay on these rules. These rules have to be implemented. The regulation of rates has to be taken forward, and various other components must be implemented. So in a sense, we are not at a very critical juncture, because the last hearing is now scheduled in November 2025. And in the next 2 months, it will be decided the case in which direction it will turn, whether it will go back to the big wrestler or whether the small wrestler will be heard. This is actually now, it's a very, very critical juncture. And that's why, one reason why I had sort of insisted to Arvinda that we should have this call, because maximum number of people should know about this. Perhaps 99% people don't even know that such a struggle, a critical struggle, is being fought. As one step in that direction, this month earlier, we organized a national webinar on 15 years of government failure to regulate private healthcare. We invited one of our speakers was a recently retired judge of the Supreme Court of India. Another was Manoj Jha, who is a very active MP member of Parliament, speaking on health issues. A representative from the private healthcare sector, Dr. Sanjay Nagral, and consumer activist Anil Jauhri. All of these they spoke about, and we had a very good attendance, more than 150 people. So it is a very good response we got. But the point is now we need to take this forward. One thing which we have done is we have brought out a set of frequently asked questions in English and Hindi, which I can circulate. These have a set of, I think, 10 or 12 questions and the answers to these questions, which explain some of the details about this entire matter. One other thing which we have done is to launch a national opinion poll, which we did on 7th of April, World Health Day. It's in 10 Indian languages. In this, it's a very simple poll. If you click on this link, it will take you to a page where you can select the language of your choice. And there are 5 simple questions with multiple answers, 3 options each. So it's very simple. You can respond to it in maybe barely 1 or 2 minutes. And it basically elicits people's experiences and opinions in private hospitals. So far, we have got nearly 1,500 responses, but we would like to have more responses so that this can be used as an input to inform the court about what are people saying about regulation of private hospitals. So this is my last slide. And basically, what can we do to support this? First of all, do respond to this poll. Circulate this link to your acquaintances, friends, family, whatever in India. It's an issue not just for poor people somewhere. It's an issue even for us, for middle class, which is facing all kinds of issues because of private hospitals being unregulated. We are now planning to start a campaign of sending emails to the Health Minister of India and the National Council, which has been sleeping for the last 15 years, that please wake up now and implement the act, which you're supposed to have done more than a decade back. So it will be good if such emails can be sent, even from the AID network or people who are interested. As you can see, today's call, perhaps there could have been more people on this call also. But anyway, we can have more such online interactions, not only with people in the US, but particularly with people in different parts of India and who are part of the AID's broader network. And we can circulate these FAQs also very, very widely. And finally, we are fighting this difficult PIL in the Supreme Court. as Jan Swasthya Abhiyan. It involves both human effort and also some financial, inputs, which are reasonably challenging because of the entire situation. So we would like to have some support even for this PIN, if possible. So I'll stop here, and maybe definitely we can have questions and discussion.